What do you say to, so let me give you an example, right? Let's be more concrete about this. So everything you said, I completely agree. And let's just sort of give you some, for the viewers out there. Let's say you have a patient who had a melanoma 0.4 millimeters in Breslow thickness, right? So if you go with the AJCC criteria and you will not recommend any lymph node biopsy, you will not do anything of those sort. And now this patient, let's say, is super anxious, let's say, and now I've seen that a lot, right? And they start asking a lot of questions, and they see other local community dermatologists, and I seen this test, genetic test, is being ordered on this group of patients because they're just super worried, right? And but in most cases, like pretty much, I mean, 99% of the time, the test coming back perhaps is just going to tell you this is benign in a sense. Is there a value here to basically give some sort of psychological, emotional relief for that stressed out patient?
Well, there would be if you knew that you could have 100% reliability in the
That's true.
results of the test. The problem is that, particularly for early stage tumors, the tests are not as accurate. The performance of the test improves with the thicker the tumor, and that makes sense because
Yeah.
the more that a tumor grows, the more likely it's going to be expressing those genes to fulfill its metastatic potential. Whereas when the tumor first starts, maybe it might express those genes, or maybe it doesn't, and maybe it hasn't really fully developed yet. And so, these are just things to consider. Like I said earlier, is that yes, you're likely to get a negative or low risk result, but you might be giving false reassurance to your patient in doing that. Some of the studies that have been published have shown that some patients with very early stage tumors who metastasized, the test actually didn't predict that. And it did predict metastasis in some patients who didn't metastasize. And so, this may all change. I mean, over time, some of those patients that had not metastasized, maybe they would down the road, but, during the period of follow-up, they didn't. And so I just think it's still sort of a gray area, and it's not clear how much extra value that test result would give over other clinical pathologic factors that you would already have available from the pathology report.
So I'm gonna.
Happened to us.
Okay.
They have a 0.4 millimeter tumor, and so we recommend no sentinel lymph node biopsy. But maybe they go to another dermatologist and they run the test, and then it comes back as a high risk result. Then what do we do?
Yeah.
And the answer is we don't know. This patient group has never been studied. And so we just don't know. And, do we do something more aggressive based on that result? The fact is, what we usually do is we discuss that patient and our tumor board and just get a consensus opinion and basically tell the patient, we don't really know what to do. And sometimes we compromise, and maybe we just do a little bit of imaging that we wouldn't normally do. If they really want to get the sentinel node biopsy, then we can do it. But, we just don't have data, a track record to look back on and say, well, it really wasn't worth it to do it in that case or not. And that's what we're faced with. So I don't personally order the test because I just don't feel like I really know yet what the best scenarios, to use it for the patient. But often the patient has the result and then comes to us, and then what do we do? So it puts us in a difficult position.
Because you are the one of the tertiary referral center, and this is a kind of a quandary, because just for clarification for the everyone out there, the public looking at this video, that is the criteria. One of the criteria for doing lymph node biopsy is if you have you offer the lymph node biopsy if you have Breslow thickness, melanoma thickness greater than 1 millimeter, right? So obviously, if it's less than 0.8 and with or without ulceration, this is 0.8, you start sort of recommending, you start talking about it, but 1 is definitely a clear cut.
Right, but I mean, those parameters are based on the risk of having a positive test result.
Sure.
So And so if we think that the chance of having a positive sentinel lymph node is less than 5%, then we generally don't recommend the test. And in general, in medicine, we don't recommend doing a test if the chance of it being positive is less than 5%. That's kind of a, just for a lot of areas of medicine, that's kind of what people go with. But the question is then, if the test result is positive, the GEP test, does that then raise it to a higher, above that 5% threshold, where then it's worth, doing the test, doing the sentinel node biopsy?
So obviously this is an example of not false positive, but you just don't know what to do with this extra piece of information, basically, right? And then that's why it puts the patient and your team in a very difficult situation, because no one have the data at this moment. And a lot of times when we're thinking about the best practice of medicine is, anytime you order a test, it should not be a knee-jerking process. You should be thinking about, when you do this, what are the downstream management plan you're going to do? If you're not going to act on it, you perhaps should not order that test, basically.
Well, exactly. And so I totally agree with you. I don't think we should order a test unless we know what to do with the result. And since we don't know what to do with the result, then I'm not inclined to order the test. I come back to, I think it would be simpler if it was a very inexpensive test, and if the sentinel lymph node biopsy was not an expensive operating room procedure. Then you'd say, well, what's the harm? If we, no one's using this test to decide, for instance, what should be the margin for your melanoma excision or something.
Sure.
Where it doesn't really make a difference if you did 1 centimeter or 1.5 or something. Then you say maybe the test really could help us. Yeah, but here you're talking about a test that's $7,000 or $8,000, and someone's paying that. If it's not the patient's insurance, that someone is paying that. And then to undergo a sentinel lymph node biopsy, for which there can be some complications sometimes, and it's an expensive operating room procedure. So, the stakes are high when you act on using these tests, I think.